Ready? Love that picture. Yeah, that's good. You ready? Yeah. Okay, well, good afternoon, everybody. Can you hear me okay? Hello. Perfect. So I'm preaching to people here that know better about post-transplant cyclophosphamide than we do, but sometimes we forget why we do things. And what I wanted to discuss today is some other uses other than haploidentical transplant that we're doing for post-transplant cyclophosphamide, and then go a little bit over some of the complications that we can see with post-transplant cyclophosphamide that we're learning about, particularly as we use beyond the haplo setting. So we'll talk a little bit about why we do it, what it's been used currently, some of the clinical outcomes on the current use, and then what are the challenges with immune reconstitution and what infectious complications and other non-infectious complications happen with it. So PTSI is an immunosuppressive strategy that is used to prevent GVHD following a hematopoietic cell transplantation. It's expanded access to BMT from alternative donors, where before we couldn't use mismatch donors in some settings. We now are able to do that. It was started a long time ago. Seattle claims it, Hopkins claims it. Everybody invented post-transplant cyclophosphamide according to them. But it really, most of the preliminary work started at Hopkins. For use in haploidentical donor transplants when I was a fellow, a long time ago, but not as long as some people in the room. I mean, we were told that you couldn't do haplotransplants. You will kill people. That's what they said. No, you can't do that. It's not going to work. And I was a fellow with Paul O'Donnell was at the Hutch when I was there, and he was so faithful about this that he actually inspired my curiosity and says, one day this is going to work. And in the US, in particularly in pediatrics, we started hearing about this mostly coming out of St. Jude. And then in the faraway land of Italy, it's where we would hear about it. and then all of a sudden it's everywhere. It has now gone from us believing in haploidentical donor transplants on POSI to even using POSI in the match-related and unrelated donor settings, and most frequently in the unrelated donor setting. So what does it do? It has two things that it does. It selectively eliminates rapidly proliferating alloreactive T cells, which essentially happen when the donor enters the host. And it also, for some reason, can preserve regulatory T cells and resting T cells, which are the ones responsible for immune reconstitution and for graft tolerance. So this is another way of looking at that. So you, when we give a transplant, you infuse everything that's in it, right? Especially for PBSCs, there's going to be CD8 effector T cells there, and CD4 effector T cells there, and CD4 regulatory T cells. And then there's non-alloreactive cells. I don't know why this is on a timer. Between day 0 and day 3, those cells all try to proliferate at the same time, right? We want some of them to be doing that, and we want some of them to take it easy. And post-transplant cyclophosphamide, if you give it, it has been done day 2 and 3, day 3 and 4, day 3 and 5. They've tried every combination. In the US, we stick to the 3 and 4 regimen. And if you do that, you tend to...
What is the dose? 40 or 50?
The 50 per kilo, there is a study right now for adults reducing the dose because some adults did not like the 50 per kilo. Their heart does not enjoy the dose. So the question being asked is how low can you go? And I don't think we know the answer to that just yet.
So
yeah,
I would say it's also important to say we're given in the adults especially because most adults are overweight. So it's always by ideal body weight.
Yeah.
And
50.
Huh?
40 or 50?
50
ideal
times
body
2.
weight.
The original, what a lot of people...
Ideal or adjusted ideal?
ideal,
Ideal. Okay.
cytoxin.
Okay.
And I'd say the original Hopkins study with bone marrow was one dose only of 50.
Right.
But with peripheral blood stem cells, when you have that 10 times more T cells, that's where the 50 times 2 came in.
I use on 40.
Yeah, we actually, for all of our older patients, we're using 40 times 2.
Mm-hmm. But again, there's a study asking a question that I think it's going to shed some light on the unrelated donor setting, not haplo.
So Dr. Myers, who talked last month to you, Dr. Myers gave her talk on the geriatric approach. She's got a presentation at the ASH meeting next month on using lower dose and our outcomes at OHSU using the 40.
So again, what you try to do is calm down and decrease the number of alloreactive cells, but keep the non-alloreactives and the Tregs as intact as you can. So why PTCy? Why not anything else? Well, first of all, it's simple. It doesn't need ex vivo graft manipulation. All the other protocols that we have to reduce the cells that we don't want and increase the ones that we don't want involve Miltenyi devices, columns, price, or a clinical trial. So we like them, but they're not easy, and they're usually particularly for places that don't have those machines or that the transplants are trying to be cost effective. It's just very price prohibitive right now. It's cost effective. It's cheap drug. Compared to other T-cell depletion strategies, and it promotes broad donor access beyond HLA barrier. So it's become a really popular form of immunosuppression in places like Thailand, like you guys, where the number of unrelated donors available it's very. Clinical uses, again, started with haploidentical. As we fell in love with that, there were studies that were looking at adding it to the match allogenic setting, related and unrelated, and I'll show some of that information. And now we're at the mismatch unrelated setting. A funny story about this, in the US, we have the National Marrow Donor Program, and they have been extra paranoid about haploidentical transplants because, their model is to sell us the other stuff. So I was laughing because for years they've been helping us collect data for haplotransplants, and I know from the get-go that their purpose was to collect the baseline data so they could improve their product. For years, I sat on the board of the NMDP where everybody kept saying 7 out of 8 donors are available for everybody. Well, nobody knew how to use them. So haploidentical transplant has done the favor to the unrelated donor setting to create a platform that now can be used for other people. And in the US in particular, the availability of haplodonors is questionable sometimes. We have the sibling there, just like your patient, the mom may be 80 and can't donate anymore, or there are other donors that I have had to work up some of the donors on the adult side, and I look at them and I go, I don't want your product. Please go home. So it's a little bit of an interesting setting. I've also been really surprised to see in other cultures when a kid shows up to be the donor of the patients usually take them. I encounter a significant amount of resistance in the US for parents to use their children. It's something that I think makes them really uncomfortable, and it must be a cultural thing. I don't know, but it feels very different to what I hear from other places. So mismatch unrelated, even though it's really expensive, the way that insurance works in the US, it's fine for now until we run out of money, which seems to be happening. So haploidentical related BMT, you guys know about this way better than I do. It's an essential source in places with limited access to other alternative donor sources. So it really is changing this landscape of transplant in places where before transplants could not occur. Example of that is the little things I've been telling you about Cuba. Cuba wouldn't be able to do a transplant if they couldn't use haploidentical. The only other thing that they can tap into sometimes, and they get them for free, are cord bloods from Spain. Everything else is embargoed in that country, and they cannot use it. They have great outcomes with modern regimens with a lot of good engraftment, low rates of acute and chronic GVHD. The non-relapse mortality seems to be similar to matched donor setting, and that was an NMDP study done through the CIBMTR. And then survival and relapse rates seem to be comparable. There was this myth for the longest time that relapse was higher with haplo. I think that was in the setting of reduced intensity and before we learn about who to take to transplant. I don't think that that's true anymore. And the challenge is that, again, not all haplo donors are available or eligible, and in the US, donor age, it's a huge issue. How old will you take a haplo donor here? What would be your oldest age? Yeah.
Oh, 75.
75, okay.
The maximum.
How young would you take a haplo donor? Yeah.
18.
18, okay. So again, some countries are using minor haplo donors, and that's the part that in the US, it's a big problem. Moving into PT-Cy with well-matched allogeneic donors. This was BMT-CTN 1703. This was a randomized multi-center phase 3 trial that I call the Hopkins versus the Anderson study. Sorry, where essentially two people decided that one thing was better than the other, and they put them head to head because they could. And it was comparing calcineurin inhibitor prophylaxis, so standard of care at the time, with post-transplant cyclophosphamide, TAC, MMF. And this was all donors coming that were matched. So match was matched sibling, 8 out of 8 or 7 out of 8 unrelated donor only. So no fully mismatch. The primary hypothesis was that the GVHD relapse-free survival at 1 year will be 15% or greater for PT-Cy TAC MMF compared to TAC methotrexate. And I remember the meetings where we were deciding about this endpoint, and you needed like tomatoes for people to be throwing at each other. It was very emotional who was going to be picked as a failed therapy. This was all adults only, what was presented here. There were kids enrolled in the study, but there were not enough kids to analyze at the end. Control malignant disease, again, in remission, undergoing any of the donors that I mentioned. PBSE only for the adults, and the kids' marrow was allowed. I knew from the beginning that we were never going to be able to evaluate the children on the study. The numbers were small, and then we were doing all sorts of different things. And then there could be reduced intensity on non-myeloablative regimen, but they were prescribed, so it wasn't a dealer's choice. And then secondary endpoints, the usual ones that we look at. Funny enough, they did not have TMA, transplant-associated microangiopathy, as a secondary endpoint here, and I wish they would have, but they didn't. So this was presented in New England Journal of Medicine. And the arms were pretty well balanced, 214 in one, 217 in the other. Similar characteristics for everything. If you look at the donor pool, it looks just like real life, about a third related, 2/3 unrelated match, and a very small number of mismatched donors. Because of the time of this study, we weren't really doing that. It was very infrequently that was on, and almost all those donors were racial ethnic minorities in the US, so non-white. The survival was good, but what we learned is that the TAC, the PT-Cy arm batted the ball out of the park, and it was the opposite of what they were expecting. So reduced acute chronic GVHD 2 to 4, chronic GVHD, and non-relapse mortality. There was no difference in relapse in this study. That really, like, I remember when this was presented, people were very excited. There was a study on microbiome going on at the same time, and I'm not presenting here because I can't understand half of the results that came out of it, but it was really interesting biology. And that essentially opened the door in the US to start testing this in a different setting. And then the NMDP jumped on board and goes, we're going to do mismatch unrelated now. They started a study called Access that has the finish enrolling way faster than I ever expected it. I mean, it really opened the door for us to be able to transplant a lot of people that were waiting. 145 adults. Again, kids were enrolled in the study, but that's still getting analyzed because it took longer. So this is just adult data, PBSC for adults, again, prescribed myeloablative reduced intensity. So I essentially imitated the other study, TAC, mycophenolate, and PTSI only. And as you can see, myeloablative and reduced intensity conditioning had ridiculous survival at 1 year. They're presenting the follow-up to the study in ASH. I didn't have the slide for that, but it looks like it's sustained. It hasn't really dropped that much. With survival over 75% still at that 2-year mark. So this is where we stopped, and then the next question was, or is right now, can we go down on the post-transplant cyclophosphamide dose? Because they did see some toxicities, particularly cardiac, on that group. And yet again, nobody's asking the TMI question, which I think needs to be asked, because that's just hard to measure. And the adult world, I'm just fascinated how some people don't believe in it.
Happens a little bit.
So what are the good news is that we can use PTSI now, and the not so good news is that we're learning some things about it. The more we do it, the more we find out, right? So what happens after you get post-transplant cyclophosphamide? The first thing that recovers within weeks is the NK cells. That's great because it can prevent some viral infections and it has anti-leukemia effects, right? So that's a really good thing. Thymic-dependent T-cell neogenesis is suppressed early, but improves over time, particularly if you're young and still have a thymus. If you're not young and don't have a thymus, do not read this sentence. Compared to conventional GVHD prophylaxis, it tends to cause delay immune reconstitution, but it's more balanced and less autoreactive. So again, the GVHD that you get with this regimen looks very different to the GVHD that you get with TAC methotrexate. So I'm dividing in the different ranges so that we kind of focus on what can happen during that time. So immune recovery wise, during the first days, you're neutropenic, lymphopenic, you have no T and B cells, and the NK cells start recovering slowly. Infectious risks during that time are the ones that you have with any other transplants, so bacterial and fungal. Non-infectious risk for post-transplant site, it's cytokine release and engraftment syndrome. Mitigation strategies are what we usually follow for transplant plus CRS management if it occurs. Do you guys, how often do you see CRS here with your haplo transplants? It seems to have kind of gone away.
Not so often.
Okay.
You cap the number of CD34 cells, so you give the whole thing.
Huh?
You cap the number of CD34 cells.
Five million.
Yeah, see that?
5 million per kilo.
Right. So that is the reason.
Right.
Because there's some centers that just give it all, and they're given 10 times 10 to the 6 CD34s per kilo. Those tend to have higher rates of CRS. I think the north side with Bashi, they're the ones who put the cap. I put 5 because I use 5 also.
Yeah, I would say at the beginning it was really interesting to see what happened during the days that we didn't know that. And that would be this patient in the room under the blankets with this look of impending doom. Like they had nothing other than a fever, but they looked like something bad was going to happen for those days. It doesn't seem to be happening as much anymore.
There's a report from Moffitt where they basically said if they gave below 5 or below, they did worse. So now they still use high dose. We have a randomized, we have a retrospective analysis to the IBMTR of looking at 5 or less versus 5 or more.
Are you capping at 5 right now?
I've been capping at 5 since day one.
Okay.
But maybe we can keep up to 8.
What's that?
8 million.
Not 5 to 8. Well, that's what we cap
We actually
everybody.
I'd say,
But 5 is safer.
Yeah, and that's where when she's asking about CRS, it's much higher when you have a higher T cell dose of a half.
I got one patient referred from Chulalongkorn Hospital. He got 12 million per kilo.
Throw it away.
With severe GI,
Wow.
GVHD.
Oh boy. This is when things start looking a little different. So day 30 to 100, again, you have quicker NK recovery, some partial T cell recovery. The T cell recovery on haplos on PTCy is a little bit more sluggish than when you do methotrexate. CD8s recover for CD4s. The Tregs are relatively preserved because the cytoxin doesn't touch them. B cells are gone. There's minimal reconstitution at that point. Viral reactivation is more common in post-transplant cyclophosphamide, and I think it's been really interesting for me to be on both sides to see how used to this we are on the pediatric side of the world because of cord blood, because it looks just like it, and how less used to it the adult population is. You have to believe in adeno, EBV, HHV6, not just CMV in the post-site setting with any donor.
Prophylactic antifungal.
We do prophylactic antifungals. Mold is a real thing on these patients, and you really need to be careful about it. But then monitoring for viral reactivation, it's also really important. And there are centers that believe in CMV monitoring and nothing else. And your patients can die from these infections. I mean, some of them are not, you don't treat them, but you can do supportive care and be pretty aggressive with it. And particularly BK, which I'm going to talk a little bit more about. Non-infectious risks during post-site that we're learning about, especially as we transplant older adults in the US, cardiotoxicity. And it can show up like anything. It is arrhythmias. It is heart attacks. It is crazy effusions that nobody understands. And patients do pretty poorly. They don't look like they have any other toxicity, and then this hits them really hard, and they can die from it. And then TMA, which Dr. Maziers does not believe in, which usually comes associated with BK hemorrhagic cystitis. It usually doesn't present on its own. Almost nobody. There was actually a paper that just came out with adult population from Cincinnati as opposed to the children's one. The association's almost 1-to-1. If they have BK, you really need to be watching for this. Yeah, and the mechanisms of it are really interesting. And at the very beginning, some people go, oh, this is just GVHD. And they actually have a really nice graph. It was an abstract presented recently. It is not associated with GVHD. You can have no GVHD and have this. By standard criteria. So monitoring for CMV in particular, which is the most common reactivation, for CMV positive or high risk CMV donor recipient combos, we use letermovir in the US. Do you guys have that available here, letermovir?
Which one?
Letermovir.
Oh, yes,
yes. Okay. They now make, for the pediatric people, I don't know if you have that formulation, but now they make these little pellets. So you can treat all the way up to babies now, where before there was that pill. So it got approved last year. Hydration and MESNA, it's used to mitigate BK cystitis, but it doesn't work 100% of the time. TMA monitoring, I believe in because I have had patients die from TMA. Not everybody needs saculizumab, and you have to have a plan to stop the darn drug. This is one part where you can't just be following serologic markers and just treating randomly. The expense of that, it's prohibitive. There's different agents. One of them is called ravulizumab, which is a more long-acting agent. It works really well. And in the US in particular, if you are from the public insurance will cover that one and not cover this one because the cost is so different. Like the other one costs more money, but you use less. So they actually have that approved instead. And then antifungal prophylaxis needs to continue on these patients. If they are on GVHD treatment past day 75, they have to continue antifungal prophylaxis. Their immune system's not ready to fight mold yet. And that's true on any allogeneic donor setting, but for post-site, it seems to be more of a problem. Past month 3, you continue the expansion. What I really like about the papers that I've read about POSI is that expansion is very gradual, which is probably why people don't experience a GVHD that we see with other patients. I'm really curious, as we're using reduced intensity and POSI, what that is going to look like compared to the historical controls. Where one thing I've noticed about reduced intensity in adults is that you send them home on day 100 and they look great, and you see them 3 months later and they have GVHD in places that you never know could exist. And I wonder if that's going to happen with a post-Psy setting. I don't know if that's one of the things that's been looking at. Let's just keep doing this. Persistent viral reactivations are a thing on month 3 to 6 with post-transplant cyclophosphamide. And encapsulated bacteria, because that B cell recovery looks like the courts. They're very delayed. The tapering of calcineurin inhibitors in the US right now for those studies, the ideal is that by day 180, they're off if they don't have GVHD. I would say that is a aspirational goal in the US because people love holding on to their GVHD therapy. I don't know if that's going to be true for reduced intensity. So what do you think?
Studies from reduced intensity.
Yeah.
So I think the study built in to start tapering at day 90 and be off by day 180. There's another approach that people have done is stay on complete full dose until day 180 in cold turkey, stop everything on day 180.
Yeah.
And I've done that in a number of patients. It works pretty well.
Even for chronic?
Yeah.
Yeah. Okay.
That's Northside.
Yeah.
Scott Solomon's paper.
And then in the US, we do seasonal influenza and COVID vaccination, or recommend COVID vaccination day 90 and above for our patients. We don't know if it works, but we know it doesn't do anything bad. So we tell people to take it. Sorry. And then 6 to 12 month period, again, you keep having progressive normalization of T and B cell counts. If you have a thymus dependent T cell neogenesis starts, I'm not sure how to interpret that on the older adult population. I wouldn't expect any of it. Yes, there's nowhere to put them. Humoral immunity reconstitutes, but I would say is reconstituting as opposed to reconstitute. Some people can actually hit the 12-month mark and still not have full B cells. Late infections are uncommon unless you have chronic GVHD or are still on ongoing immunosuppression. And then hypogammaglobulinemia-related infections are more common on people that have received post-transplant cyclophosphamide. We initiate revaccination in the US around day 180. And then some people need IVIG replacement. There's no guidelines on how to do this or what a number to use. So in general, what the recommendations right now are, if you are having someone with low IgG and infections, then treat symptomatically. And then VZV, varicella zoster reactivation is an issue. We keep everybody on acyclovir until they hit a year, sometimes longer, I think.
CD4.
Yeah, using CD4 counts. Over 12 months, you shouldn't be having problems with immune recovery unless you have GVHD, and immune memory starts restoring. You can still have opportunistic infections, but they're much more rare unless you're still on immunosuppression. And long-term infection risk is mainly driven by, again, if you had GVHD and immunosuppressive therapy. It's just really interesting to look at the literature for people that have had foci and they end up having GVHD. Those are really infected patients all the time. Like when they get hit, for the very few that don't read the book and get GVHD, that's really bad. They're just beat up.
We know.
Yeah, yeah. So it's really, I would love to understand the biology of that particular type of patient because I think they're probably going to need a different way to do things than what we do for other patients. So this is a short talk because I just wanted to have more of a discussion because I think you guys can teach us more about what you do here than what we can teach about what we're doing in the US.
Thank you.
Yeah, no, every time I get on phone calls with you guys, you have these patients with these crazy infections. I'm fascinated about how difficult it is to manage those patients because you have them away. They're no longer here. So I wanted to hear a little bit more about how you monitor them from afar, which we probably need to learn how to do better.
So my question I already have is with this regimen, the post-transplant cyclophosphamide plus the either tacrolimus or the cyclosporin and Celsep can totally should totally prevent GVHD, but not in all cases.
I don't know.
How
It's a
could you
zero.
explain that?
What was the question?
The question is with this regimen, theoretically, should prevent totally the GVHD. But we still see some acute and chronic GVHD.
Yeah.
You can't get it all.
I know, but what are the risk factors for those?
So that other study that hasn't been resulted yet, the companion study to the therapeutic study, is looking specifically at biological markers. And there's this whole theory about influence of the microbiome and baseline immune characteristics of the host. But I don't have the results of that yet.
One of the things that comes up is, again, biologically, you give Cytoxan on day -3, day 3 and day 4. Because if you think of a mixed lymphocyte response, the classic MLR, you harvest at day 6. And with mismatch, you'll have 100% of your clones. And so you just intervene at the day 3 and 4 is arbitrary to kill off the proliferating high affinity clones.
Right.
Remember, those clones are low avidity. It's going to take time to see and target antigen before they'll be turned on to trigger. Maybe you might be more successful giving a dose at day 3 and day 7. Kill the day 3 cells, which is the fast, and then day 7 you come in and get the lower avidity clones. That may be better, but then you may have a higher relapse. Because the whole idea of a low avidity clone is it's giving you minor antigens. You want to get rid of the HLA specific peptide that's high affinity. So you're going to be, you can't eradicate it all. That's the way, if you eradicate it all, it's just like doing a T cell depletion on a Clinimax. They relapse. So, it doesn't surprise me when you think of the molecular basis. I do think what's interesting is there's a pediatric colleague has looked specifically at this data set and did complete T cell sequencing on every patient going through on both cohorts. The data they call, you alluded to it, but she calls it the T cell bottleneck at day 30. Because if you look at the number of clones that are functioning, they're sort of equivalent early on.
Is that messy?
Yeah. The TAC methotrexate stays, at this way and then expands. The PT side goes like this, like down. And it's a really narrow set of surviving clones that re-expands. So she's published a first paper on it, but there's going to be more coming. But it's, I think it's something to do with, the answer to your question, I think, could be, why are we using day 3, 4? Why did at the end of the day, it's not a lot of magic. It's cyclosporin and post-transplant chemo. Post-transplant, so methotrexate versus Cytoxan, they're just a drug that are immune suppressive. We use methotrexate for autoimmune disease. It works. You use Cytoxan for autoimmune disease, it works. But when we give methotrexate, we have 1, 3, 6, 11. if you do, Bill Benzinger
Mhm.
did an analysis once of, a big meta-analysis of one, if the patients didn't get day 11, they got 136 and they didn't get day 11 because of mucositis. There was no difference in acute GVHD. There was more chronic. So the day 11 dose, I always will get something in, even if it's 2.5 milligrams per meter squared.
The problem I have with the analysis of that paper is if you then look at Jamie Ferrara, damage to organs theory, somebody that was sick enough to not get their day 11 methotrexate also had a lot of broken body parts that day. And is this an antigen presentation issue, or is this
True.
you didn't get the
There's a lot of
methotrexate?
biology.
Yeah.
I'm just saying, but all I'm saying is the day 3-4 is everyone's wedded to it, and now it's that's what we do. But that may not be the best. That may not be the way to get rid of the chronic GVHD in this patient.
And it's the Genova people don't do it that way.
What?
It's the Genova regimen. It's not
Oh, really?
Yeah, it's something else.
Between day 3 and day 5.
Day 3 and 5.
Day 3 and 5.
Yeah. Yeah.
But I mean, I think it's like, again, that dose 11 methotrexate made a big difference.
Yeah, but in the 1703 study, that study, the rate of grade 2 to 4 GVHD was 53% on the experimental group and 52 on the standard prophylaxis group. 3 to 4 was different, 6.3 on the experimental and 14.7 on the control. And then chronic GVHD was different, which goes along with what he was talking about, the what expands. So it was 22 on the experimental arm and 35 in the standard arm. So it was a bad GVHD. That was a difference. The regular one was the same for everybody. Yeah.
Okay, interesting.
Yeah. Like I think I'm really curious about that second study and all the things that are spinning out of it, because I think we're going to actually be able to understand some of the things that are coming out in the meantime. Yeah, and maybe hopefully make it better. The issue with transplant that I love is that we love the new thing, and then everybody jumps on it, and then we stop studying it.
They stop studying something to make it better.
Yes, I'm glad that biology was asked alongside with this protocol, because otherwise I don't think we'll ever get the answers for it.
So thank you very much.
Yeah, thank you.
The chat. Then theyคุยต่อผมไม่ต้องอยู่นะ
Thank you very much. I'm on the video call, not disappear.
See you later
อาจารย์เทียนชัยอยู่ใช่ไหมคะ
อยู่ครับเข้ามาแล้วครับ
อ๋อโอเคอาจารย์เมย์เข้ามายังคะพอดีมองไม่เห็น
อาจารย์มานานแล้วครับ
อ๋อโอเคอาจารย์คะถ้างั้นขออนุญาต sign off ทุกคนเลยแล้วกันนะคะอาจารย์จะได้มี private discussion นะคะฮัลโหลeveryone please sign off นะคะ we finish for the day okay and we see you back again tomorrow thank you very much ค่ะ
รับทราบค่ะขอบคุณค่ะ